Hello, everybody. Welcome on this next live event of ETGOM GCI. So I hope you are all very comfortable, you are relaxed. And I also hope that, of course, we don't face any technical problems today, because without internet, nothing functions, of course. Well, today's topic, as you know, we're going to talk about the straight leg race. And I immediately have one question for you. What is your definition of a straight leg race? When you registered for this webinar, then you had the opportunity to give your opinion on what exactly is a positive straight leg race. And many of you did that. I got about 45 reactions or so. And before we talk about a positive straight leg race, then we need to know what exactly is a positive straight leg race. And I've noticed that my definition of a positive straight leg race is not necessarily your definition. And just to give you a little idea, I just summarized a few of the so-called definitions here on this slide, and you immediately see that, let's say there is some difference in opinion, some discongruence, so to speak. For some people, the straight leg race is positive when it produces leg pain. When it doesn't produce leg pain, it's not positive. Or you need to produce symptoms between 30 and 60 degrees. And if you have symptoms further than 60 degrees, then it's not related with the spine anymore. It's a hip problem, and so on and so on. So how can we optimize those things? How can we come to a more, let's say, standardized definition? Well, let me help you with that. But before we do that, I'm, of course, very curious to know who you are and where you are from. I got registrations again from all over the world, and feel free to introduce yourself in the chat. In the meantime, I can welcome Barbara from Slovenia, Marin, welcome Hristo from Bulgaria. Welcome. Well, we're going to see each other, if I'm not mistaken, in June, I think, for our next course in Bulgaria. And Josica, of course, also welcome. When you put something in the chat, Darek from Poland, also welcome. When you put something in the chat, keep in mind that when you're writing that, there is some little delay before I can read it over here. But during the webinar, when you have any specific questions or things which are not clear, just put it in the chat, and once in a while I'm going to have a look at the chat and going to see how I can help you. Ziva from Slovenia, Ardit from Kosovo, and look who is there, Dr. Peter from The Han. Very nice surprise, welcome. Well, for those of you who don't know me yet, I'm Stephen. I'm responsible for Global Cyriax Institute, and together with my team of doctors and physios, we teach courses in orthopedic medicine for doctors and physios all over the world. So if you would like to know where we are, then you just go to this link and you'll find our international course planning over there. But the reason why, again, I'm sharing some stories with you is actually because of my father. My father used to be a physio over here in The Han, where I live, and he was, let's say, a very close collaborator of Dr. Cyriax, and he introduced concepts of orthopedic medicine all over Europe. And you can imagine when I was a youngster, the only things I heard in my neighborhood was orthopedic medicine. And as you can see on this image here, well, the guy who's lying on the table, that's my father. And this picture has been taken in the clinic of my father many years ago. And the other guy who is doing some cervical maneuver, he's a colleague from Holland doing his exam, and Cyriax is watching there. And the yellow guy, the assistant in the game, believe it or not, but that's me. So when they asked me when I was a young boy, what are you going to do when you grow up? Then, well, it was already clear very early what I was going to do. And then, of course, after the exam, together with the wife of Dr. Cyriax and some other people, I could do the dishes and enjoy a glass of champagne. The yellow guy at the left, that's me. Believe it or not, but some things change, of course. That's a little bit my background. And at this moment, I'm broadcasting from the so-called Rainbow House. And over here, I organize the Mastermind Private Training in Orthopedic Medicine. But I tell you something more about that later during the webinar. In the meantime, we have some other guests from Tasho from Bulgaria and Soyana from Qatar. So welcome, join the club. Those of you who already know me, you know that I go straight forward to the point. I don't lose too much time. It's fantastic that you joined this webinar together with me. So we're going to need about 1 hour max, I guess. And during this 1 hour, I would like to share you some practical insights relating the interpretation of straight leg raise. But I'm sure you're going to discover a few surprises. But everything depends, of course, on your clinical reasoning system. When you are confronted with a patient with lumbar problems, then the eternal question is, how do you examine your patient? Which questions do you ask? Which functional tests are you doing? Which methods or which tools do you use to come to a certain conclusion? And then the next question, of course, is how valid is our conclusion? Well, there are a lot of different options. There are some valid options, there are some less valid options, but to discover more about that, I refer you to all my other films which are online on our website. I refer to the online learning platform, my YouTube channel. There are a lot of resources where you can find more information about that. But it's all about collecting puzzle pieces. Just like, okay, positive straight leg raise, whatever the meaning is of positive, but we're going to specify that a little bit later on. Just a positive straight leg raise does not mean anything in your clinical examination. We are always looking for puzzle pieces from the history, from the functional examination, and then you put everything together, and then you come to a conclusion. Many of you already downloaded my ebook on, it's an actual book, but it's also available as an ebook, the book on clinical reasoning. It's about 156 pages. And in this little book, I explain how the clinical reason system works. You just go to my website, more details later, and you can download it, of course, for free over there. Okay, we're talking about straight leg raise. Surprise, surprise. But before we do that, let me ask you something, because of course I'm curious to know who you are. Well, my first question is, and if you look at the right side of your screen, you should see a question over there. Is it the first time you joined a live webinar with me? And you can click on yes, or you can click on no. And I'm curious how many people here in the group are first time with me. And if I look at the score now, then wow, it's quite surprising. Yeah, the score more, yeah, it's 60% first time, 40% already joined me on a previous occasion. Yeah, nice. Well, for those of you who see me now and hear me now for the very first time, welcome. I have another question for you, but I have to take care of the digital technical aspect over here. I'm curious. Did you ever attend a live Cyriax course or a live course in orthopedic medicine, a live course in musculoskeletal medicine? And well, that's also a nice score. But about 40-45% say no, I didn't do that. I did that, yes, and about 60% says I didn't do it. Well, at the end of the webinar, I'm going to give you some more information about our live courses. But of course, I have some more questions for you. And one of the next question is this one. A positive straight leg raise does not cause low back pain. What do you think about that? Is that true or is that false? A positive straight leg raise does not cause low back pain. I'm curious. What do you think? Whoa, really? Is 100% saying, okay. About 57%, about 50% says it's true. Okay, it's 50-50. So half of you, a little bit less than half of you are saying, indeed, a straight leg raise does not cause low back pain. Well, then I have a little surprise for you. The answer is false. So half of you interpreted that in a nice way. And I'm going to explain that to you a little bit later on. A positive straight leg raise can perfectly cause back pain without leg pain. But that's going to become clear later on. And perhaps one more, one for the road. Okay, there must be nerve root compression. I see I made a spelling mistake over there. My apologies for that. There must be nerve root compression if the straight leg raise is positive. Okay, I see that again. It goes in the 50-50 direction. Well, let me also surprise you over there. It's perfectly possible that if there is nerve root compression, that the straight leg raise is completely negative. This is possible. It's also possible that the straight leg raise is positive. Okay, so you see, we have to interpret some things. Okay. We all know that a straight leg raise is a test mainly for the nerve roots L4, L5, S1, S2. But what many of us seem to forget is that the straight leg raise is also a dural test, is also a dura mater test. And this is going to have pretty important clinical consequences. So straight leg raise is not just a straight leg raise. You're going to be surprised how much information we can distract by looking in a certain way to the straight leg raise. So in the meantime, if I go too fast, if something is not clear, just put it in the chat. Yeah, just let me know, okay? Of course, when you do the straight leg raise, first you're going to do it on the pain-free side. That's obvious. Because if you do, for instance, if you do straight leg raise on me, I am Mr. Stiff. My normal range of motion of straight leg raise is about 70 degrees. I'm stiff. Yeah? And you don't want to confuse stiffness with a positive straight leg raise. You don't want to confuse tight hamstrings or some tension in the hamstrings with a positive straight leg raise. I remember one of my patients, a lady of, how old was she? A lady of 70 years old. She had a straight leg raise of 120 degrees. She was super mobile. Yeah, so fantastic. But you do the straight leg raise, and you don't ask to the patient, does that hurt? Yeah, people who already follow me since some time and who are more familiar with orthopedic medicine, then you know that you never ask to your patient, when you do a test, does that hurt? Because this is a very confusing answer. Whenever you do a test, whatever test you do, you always ask, does that change anything? And then the patient says, yes, it hurts. But don't automatically assume it hurts in the leg. Always ask to the patient, yeah, tell me, where does it hurt? And then he can say, it hurts in the leg. Okay, where? It hurts in the gluteal area. Where? It hurts in the back. Where? Yeah. This is information we need. If the patient has leg pain during a straight leg raise, that could be related with nerve root compression, but that also could be related with dural compression. So at this point, I can't make a clear distinction yet. I will need more puzzle pieces. Keep in mind that we do the straight leg raise in a passive way, because on different occasions I saw a therapist doing a straight leg or asking to the patient, okay, lift up your leg. Okay. Doing straight leg raise in an active way, doesn't make any sense at all. Because when the patient then says it hurts, this kind of information is completely irrelevant, for several reasons. So always do it in a passive way. But we do the straight leg raise in a passive way. And at a certain moment, the patient says, oh, what do you do then? Then you stop. You don't come back. No, you stay there. And you ask to your patient, where does it hurt? And then he says, okay, my leg, gluteal, back, wherever. And then you try to continue. Try to go further. And then there are two options. Or the patient says, oh, stop. Okay. Then you interpret this. Okay, you have minus 30 degrees range of motion in the straight leg raise. Okay, pain over there. Perfect. But it happens very often when you try to continue the movement that the patient says, oh. But when you continue, then the patient says, oh, now it's okay. Now I have less pain. In other words, you find, and that's super important, you find a painful arc during straight leg raise. So no pain at the beginning, pain somewhere in the range, you go further and the pain disappears. This is super. And why is this super? Because this is a fantastic clinical finding. And what is the interpretation? The patient has with certainty a small internal derangement. Okay, what is our definition of internal derangement? Disc protrusion, disc bulging, whatever name you would like to give to the child. Deformation of disc material with pressure against the sensitive structure. This sensitive structure could be the dura mater, could be nerve root. A painful arc is typical for a small internal derangement. And this is very good news, because when you are going to treat a patient, then you already know that you're going to be successful very fast, because it's easy mostly to reduce a small internal derangement. Okay, more about reduction of derangements in other webinars and other films which are on my website. It's not only small, it's not only easy reducible, but it's also certainly not a patient with, let's say, psychosocial component, because we all know that a number of back patients are not just mechanical patients, but there are also other influences that play. Some psychogenic influences, some stress influences, and so on. A psychogenic patient is never going to show a painful arc. This is a real patient, a real, let's say, honest patient. Okay. You try to go as far as you can, as far as the patient allows you to go. But at the end of the straight leg raise, so at the patient's end, you ask again, okay, does that change anything? What do you feel now? And then the patient says, yeah, it hurts somewhere in my back. Okay, for instance. And then you ask the patient, could you please lift up your head? Yeah, in other words, can you do an accessory neck flexion? Many of you are familiar with the accessory dorsiflexion in the foot. Okay, nothing wrong with that. But actually, I don't need this extra test. Extra neck flexion is more interesting. And what can happen? Well, the patient can say during the extra neck flexion, nothing changes. I feel the same as I felt before. Or the patient says, ooh, I get more pain. Or the patient says, strange, I get less pain. I love it. More pain on neck flexion and less pain on neck flexion. Both of them are fantastic dural signs. And when you find a dural sign in your examination, then you practically can be sure that the patient has a symptomatic internal derangement, some discodural, discoradicular conflict. What's the mechanism behind it? Why can the patient get more pain, get less pain? Well, the dura is mobile, and when you do flexion, the dura moves in cranial direction, moves a little bit in anterior direction, and depending on the size of the internal derangement, the protrusion, the bulging, whatever, depending on the location, then it's and depending on the mobility of the dura of that patient, and this is inter-individually different, then the patient can have more pain or less pain. So those are simple things which you can discover very easily in your daily practice, but which have clinical consequences. You do the straight leg raise. You ask the patient, does that change anything? And then the patient says, yes, it hurts. Where? Let's imagine you do the right straight leg raise, and then your patient is saying, it hurts on the left side. Somewhere in my back on the left side. This is what we call a crossed straight leg raise. And in the answers I received on the question, what is your definition of a positive straight leg raise, was also one of you mentioned this crossed straight leg raise. You don't see that so often, but it happens. We have to keep in mind that the dural sheet around the nerve root is mobile. The dura is mobile. And when you do a straight leg raise test, automatically you also get tension, again, depending on the mobility of those structures in this patient. You can also get some tension on the other side. And as you can see on this image, it's quite possible that there is somewhere an internal derangement squeezed in between dura and nerve root, and that the contralateral straight leg raise produces symptoms. I love it, because when you see that, when you see a crossed straight leg raise, okay, this patient has an internal derangement. Yeah. You already know that the value of medical imaging in relation to diagnosing lumbar spine problems, this value is rather limited. From the differential diagnostic point of view, that could be interesting, of course. But telling me if there's an internal derangement on that level, that's interesting, and it's also not that relevant. But again, I wrote some articles about that on the website, some films. I refer you to the other content. Yeah. Everything okay until now? Yeah. No surprises, no questions, because if you have any questions, just drop it in the chat box. Okay. Of course, your straight leg raise can not only be painful, but it can also be limited, or painful and limited. And yeah, it could be limited unilaterally, but it could also be limited bilaterally. And what could be a reason for that? Well, let's imagine you have a sciatica. A real lateral protrusion with pressure against the nerve root. So you have nerve root compression, you don't have dural compression. Well, in that case, you can expect a unilateral positive straight leg raise, and perhaps, depending on the size of the derangement, but I come back to that a little bit later on, you can have a unilateral limitation. But if you have a posterocentral protrusion, and the best example is an acute lumbago. Sooner or later, we are confronted regularly with a patient with acute back pain. Yeah, the patient is completely blocked. He has a lot of back pain. He has radiation, multi-segmental radiation of pain. Perhaps he has a flexion deviation. He's blocked. Perhaps he has a lateral deviation in standing. Yeah. This acute lumbago patient must have a positive bilateral straight leg raise. Straight leg raise is bilateral, painful, and limited. If this patient has a big discodural conflict with pressure against dura. Let's imagine you have an acute lumbar patient, and you don't have dural symptoms, you don't have dural signs. In other words, no pain on coughing and sneezing, no dural signs, so no symptoms on neck flexion, straight leg raise negative, and so on. The reason of the back pain is not an internal derangement. Remember, it's all about collecting puzzle pieces. Yeah, let's imagine this patient. You see clearly that he's a little bit off center. Yeah, he has a very nice lateral deviation towards the right. When you see something like this, in 99.9% of the cases, he has an internal derangement. And a deviation automatically means it's a bigger derangement. In other words, the therapist, whoever treats him, look at him. He's really off center. We need more treatment sessions. You're not going to solve that in 1, 2, or 3 sessions. Yeah, that's highly unlikely. Okay, and it's quite possible that this patient has a wonderful positive unilateral straight leg raise. Yeah. Okay, so depending on the size of the disco-radicular conflict, depending on the location, well, your straight leg raise can be more or less limited, can be unilateral symptomatic, could be bilateral symptomatic. Okay. Christo, from Bulgaria is asking, does the crossed straight leg raise points in the direction of an L4 protrusion? My honest answer is, I don't know. Yeah. And the good news is, I don't care. I don't need to know. If the patient has an L4 protrusion, L5 protrusion, L3 protrusion, I don't care. I need to know that the patient has an internal derangement. But I don't care because, first of all, I don't have any objective tests to come to this conclusion. But secondly, my treatment strategy, as described in other films, is specific. So I have as much effect on the L3, L4, L5 disc. So, okay, I don't care. But if you come back to that patient who is, well, most likely he has more chances to have an L4 protrusion in comparison to an L5 protrusion. But this is an empirical. Because between L5 S1 there is less mobility because of the presence of the iliolumbar ligaments. Between L4 L5 there is more lateral shift mobility. But okay, this is a possibility. But nice to know, but not necessarily need to know. Okay, but my straight leg raise, if you have a positive straight leg raise, he's my tourist guide. He tells me whether my treatment strategy goes in the good direction, yes or no. And what do I mean by that? Let's imagine you decide, depending on different elements from the clinical examination, that this patient could react well on some kind of manipulative technique, some kind of stretch technique. And okay, we see here, for instance, a basic so-called stretch manipulation. Okay, you do a manipulation, and what is a basic rule in orthopedic medicine? You do one manipulation, and then you check your positive test to see whether something changed, yes or no. If it's better, then I continue, never change a winning team. If it's not better, then perhaps I'm going to look for another technique, whatever. Yeah. I also, in the past, I did a webinar on how to choose which manipulation. I recently also put an article about that on my website, but I show you the link a little bit later on. But what I want to say is, if your straight leg raise is positive, you do one manipulation. What you do immediately, the patient is lying back on his back, and you check the straight leg raise. If the straight leg raise was painful and limited, I check, oh, okay, less limitation, that's good, I continue. Or let's say that the straight leg raise was end range painful, okay, you check, oh, it's not painful anymore, okay, you continue. Or, that's also possible, it's worse. Suddenly, your straight leg raise is more positive than it was before. And this is also useful information. So really, our straight leg raise is a very important guide during our treatment session. And if your straight leg raise would be negative, but you have other positive tests, we use the other positive tests as a guide in our treatment session. Okay? In the meantime, I have a look at the chat. I see that Evalio posted another question. What might be the reason a patient with low back pain on only one side that improves with auto traction has a negative straight leg raise? I'm not 100% sure what you would like to know. what you mean with auto traction is that the patient who hangs at the bar somewhere in his garage and he uses his body weight to get some traction effect. If it is this what you mean, well, in many cases with internal derangement, a traction effect by manipulation, mechanical traction, certain exercises, in many cases that's pretty beneficial. That reduces the intradiscal pressure. You create a negative pressure, allowing some kinds of internal derangement to reduce. So yeah, and then it's perfectly possible that the straight leg raise, which was positive, becomes automatically negative. That's absolutely no problem. I refer to the website, to Cyriax.eu, and you see it also above the chat. I put a sticky message there, discover the knowledge bank on Cyriax.eu. Well, knowledge bank, I put more and more information over there. At least each month I put new articles and practical articles. For instance, lumbar spine manipulation, which techniques are you going to use? Well, I explain in detail when do you do which technique, how do you do the technique. I put films over there of the techniques, so all which can help you in daily practice, you can find it over there. Mm-hmm. But how positive is our straight leg raise? Well, that's also something interesting to know. You have different phases in a so-called positive straight leg raise. It's perfectly possible that your straight leg raise is negative. I love it. Yeah. But something which is very often forgotten, very often you see that a straight leg raise is painful end range. There's no limitation of movement, but you just have end range pain in the back, gluteal area, leg, whatever. And as I mentioned before, you could have a painful arc on straight leg raise. Well, how do you interpret this? Well, if you find one of those, and the other elements, the other puzzle pieces in your history and clinical examination point in the direction of an internal derangement, you may be sure that it is a small internal derangement and it is relatively easy to reduce. So as a therapist, you're going to be pretty successful pretty fast. But okay, as you perhaps know, reducing an internal derangement is not always a problem, but keeping it reduced is another problem. And therefore, of course, prophylactic strategy is super important. Well, the last webinar I gave, I think, was it January, was about back pain prevention. How can you motivate? How can you inspire your patient? Well, you can find this webinar also on the website and on my YouTube channel. But sometimes a straight leg raise is painful, limited, but you don't have motor deficit. What does that mean? That means that the problem is a little bit bigger. It's a bigger internal derangement, but no panic, we can still treat. But if you find a straight leg raise which is painful, limited, and you have motor deficit, which you found in your examination. We did a number of root tests, and let's imagine the patient has, let's say, pain along the L4 dermatome, straight leg raise, painful, limited, and in your examination you also find motor weakness of tibialis anterior, let's say a drop foot. That means that there is quite a lot of pressure on this nerve root. Can we do some physio techniques Yes, you can. Are you going to be successful? Perhaps. Perhaps not. Again, it depends a little bit on how big is the internal derangement, and is there already serious damage to the nerve root, yes or no. So so this is tricky. Yeah. But something which is strange and fortunately not frequent is a patient with an ischemic root atrophy. So that's a sciatica patient. Yeah. He has pain somewhere in the leg, compression on a certain nerve root. He has a lot of pain. The sky is the limit. Pain. The physio can't help him. He goes several times to his doctor because, doctor, help me, it hurts so much. And the doctor does all he can, but the pain is really too much. And at a certain moment, the pain is gone. And the patient feels much better. And the straight leg raise, yay, full straight leg raise, no problem. But when you do your motor examination, maximal motor deficit. So what happened? The pressure on the nerve root was that big that at a certain moment, the nerve root became ischemic. So the patient became, let's say, anatomically worse, massive compression on the nerve root, but symptomatically better. Okay, he has weakness, but I don't have pain anymore. Yeah. Of course, let's try that it doesn't come that far, yeah, because that's, of course, a patient for the neurosurgeon. An interesting question again in the chat. What can we conclude if the SLR, if the straight leg raise is negative, but the patient has a painful arc in lumbar flexion? Very nice question. Thank you for that. Well, what is flexion in standing? Flexion in standing is exactly the same as a straight leg raise, with one difference: it's a test under compression. And straight leg raise is a test under decompression. So the example you give is perfectly possible. Your straight leg raise negative and a painful arc on flexion in standing. Remember, you ask the patient to do a flexion. At a certain moment, you ask him, does that change anything? The patient says, oh, it hurts. Go further. Don't stop at the first pain, and then you discover a painful arc. The interpretation of a painful arc on flexion is exactly the same as a painful arc on straight leg raise. It's a small internal derangement. It's easy reducible. It's not a psychogenic patient. I love it. Okay? But there is another option. You could find a straight leg raise which is slightly limited, 10-20 degrees limited. Perhaps slight leg pain. That's it. And if you repeat the straight leg raise several times, if you do it 5 times, if you do 10 times in a row, you find 10 times the same result. But if you listen carefully to the story of the patient, well, the patient had in the past had a sciatica, a real sciatica. And apparently there was some damage in the nerve root dural complex. And it's quite possible that at a certain moment, because of the healing process, you create some adhesions over there. And those adhesions can create a so-called dysfunction syndrome. That's what our colleague Mackenzie described already many years ago. And of course, this patient doesn't have an active internal derangement anymore. This patient has a problem with scar formation. And that's a dysfunction syndrome. So this patient, he doesn't need manipulation, mobilization, traction. He doesn't need all of those things. This patient needs an exercise program. This patient needs a so-called remodeling program. Yeah? So therefore, it's so important that you carefully listen to the story, that you interpret your puzzle pieces from the functional examination, and then you can come to this conclusion. That also happens a lot after surgery. They get adhesive problems. So that's why it's so important that after surgery, patients try to move as soon as possible, and preferably end range in different directions. But of course, we have to respect the work of the surgeon. That's logical. But as soon as you can, move. Voila. That's a compact overview of how you can interpret a straight leg raise. So my question to you is now, are you ready to implement this in clinical practice? Of course you are. But everything, I mentioned it already several times, it's all about patient selection. Now, after this short session together, it's obvious for you that a straight leg raise is not just a straight leg raise, that you can extract a lot of interesting information from the straight leg raise. So I'm looking forward to your ideas, your suggestions, your questions. If you have any questions, please feel free to put them in the chat. If I can help you, I'm going to do that with pleasure. So use the chat. In the meantime, what could you do in the future? Well, knowledge without action, of course, is pretty irrelevant. So it would be nice if you can do something with this. Well, I offer you 3 options. And one of the options is, well, if you have the opportunity to follow a seminar with me or one of my team members, we are all over the world. So specifically my team members, well, just have a look online and perhaps there is a seminar in your neighborhood, and then you can contact our local organization partner. I have a premiere news for you today. Really, today, we reached an agreement with a colleague in Lebanon, in the neighborhood of Beirut. So this year we're going to offer some new courses in Lebanon. My colleague from Italy, Alessandro, is going to be responsible for those courses. But more information will appear online pretty soon. Or if you want to come to my place, if you want to come to the Belgian coast, then over here I organize the Mastermind private training program. This is an exclusive 7 days program for maximum 4 guests. So it's really exclusive, but also very intensive. You find also all the information online if you want. My next session is at the beginning of September, from the 11th to 17th September. And there are 3 seats left, so it goes fast. But this is the most unique experience you can have. Okay, when I tell you that, you don't have to believe me, but look at the Mastermind page and you're going to find a lot of video testimonials of a number of doctors and physios from all over the world who were already my guests. Look and listen to what they have to tell you. Perhaps that might be an inspiration. And I have a next premiere this year. Well, I'm going to appear in a bigger image now. This little box here. And what's in the black box? Well, in the black box, there is a gold bar. The orthopedic medicine gold bar. It's not a real gold bar, unfortunately, but the content which is on it is pretty, if I may say so, is is pretty gold bar like. If you look on the right side of your screen now, then you're going to see a link to the specific page where I give you all the information on this gold bar. And what can you find on this? Well, at least 17 hours of films, all my lectures on orthopedic medicine, so everything about clinical reasoning, diagnosis, differential diagnosis, treatment strategy, all the treatment techniques, also for medical doctors, all the infiltration, injection techniques, everything is on the gold bar. You just have to plug it in and it's yours. You have all the films, all the material, and you can look at it whenever you want. Yeah, and that's, I think, quite an interesting investment you can do to implement things in your daily practice. So if you have more questions about that, okay, just let me know. Yeah. Voila. So in the meantime, any more questions? I'm going to have a look in the chat. Yeah. Another question. In neurological deficit, what are the guidelines to continue with conservative treatment? Wow, nice question. Well, no panic. That's a guideline number one. I hear too often when the patient has a very nice sciatica and perhaps with slight motor deficit, I hear too often that people say to the patient, oh, you have to go to surgery immediately because you're going to end up in a wheelchair and blah, 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 blah. No. It all depends on the situation. In literature, we see that very often there is a spontaneous evolution when it comes to sciatica, when the patient has pain, but also when there is motor deficit, a mechanism of spontaneous evolution exists. And more specifically, a monoradicular deficit recuperates in an average of about 7 months without treatment. If there is a biradicular deficit, the numbers are not that good. But everything, it's a decision which is made between the doctor and the patient. Let's imagine the patient has this sciatica with motor deficit. It's recent. Yeah, he already has 1 month of leg pain. His deficit is recent. You as a doctor, you discover that. Yeah, which choice are we going to make? Nowadays, with, of course, modern minimal invasive surgery, perhaps at that point, it's a good idea to refer the patient to the surgeon. Yeah, that's 1 month symptoms. Let's say 3 months after surgery, he recuperated pretty well. So in 4 months' time, yeah, nice. Yeah. But let's imagine your patient already has 6 months of leg pain and the deficit is already older. Are you then going to decide to go for surgery? Well, yeah, you have to talk with your patient then. The chance is pretty realistic that without surgery, a few months later, it's going to be okay. And he doesn't have the risk of the surgery. You see, bottom line of the story, motor deficit is not always per definition an absolute reason for surgery. Yeah? Take into account the mechanism of spontaneous evolution. Okay? Voilà. Thank you very much for your nice question. Any other questions? Well, we are already live 54 minutes and 4 seconds. So I also have the habit and the tradition to stick within the time frame I set, also out of respect for your time, because you have also many other things to do besides watching this webinar. So if there are no other questions anymore, then I would like to thank you very much for joining this webinar. And of course, I have to end with a picture from the sea, because those who joined my live courses, you know that there are a lot of sea pictures in my presentation. So with the sun going down, looking forward to a nice summertime. I thank you very much for joining this webinar. I hope it was interesting for you. You discovered some new things. Watch your mailbox. After this webinar, you're going to receive an email with the link to the replay version of this webinar, so you can watch it again if you want, whenever you want. And there are also some links in the email to the knowledge bank, to the download platform, and so on. Okay? So enjoy the rest of your day. Thank you very much for joining. And well, I'm going to conclude for tonight. And special greetings to Dr. Peter, because we live pretty close to each other, and we see each other tomorrow morning in the clinic. So thank you very much, and bye-bye to everybody. Ciao, ciao.